Welcome to another episode of UroChannel, and I have a very special guest with me. It's Amadea Kezar, physiotherapist from Montreal in Canada, and she's a very enthusiastic speaker and a member of the Canadian Society for Pelvic Pain. Is it right?
I am, yes.
So welcome to our show, and I'm very glad that you're here.
Thank you for having me. It's a pleasure.
Okay, so let's start. Amadea, what are the symptoms of an overactive pelvic floor?
The symptoms of an overactive pelvic floor. Okay, so there are a few. So it could be urinary issues. So urinary urgency and frequency. We see dysuria, pain on emptying the bladder, post-micturition dribble as well. So feeling like you're incomplete once you've emptied your bladder, or you've emptied, you start to walk away and there's a little bit of dribbling. You can have pain in the genitals, in the abdominals, in the perineal area, which is that band between either the vaginal opening and the anus or the scrotal tissue and the anus. And some people have anal pain directly. So we can have a melange of all of these symptoms or some of these symptoms, but all of them could have an underlying cause being overactive pelvic floor.
Okay. What about sexual problems?
Where sex is concerned, then we see pain on penetrative intercourse, sometimes deep dyspnea, so pain with deep penetration in the vaginal canal, as well as pain on erection and ejaculation, or pain that lingers after erection and ejaculation.
As a matter of fact, I've discovered the pelvic floor like more or less 2 years ago, and that was connected to the pandemic because all of a sudden I had two huge masses of patients coming in with pelvic floor issues. So what we call in urology the chronic abacterial prostatitis suddenly came to my office in huge masses of patients, and everybody was complaining about this pain in the perineal area and all this urgency and post-micturition dribble. And I started to question the concept of chronic abacterial prostatitis because by chance I came across the treatment of these symptoms with shockwave therapy. So one of my first patients was an old friend of mine, and he was suffering from this big time. So when he came into my office, he was literally crying, and he couldn't sit on a chair. So he had to like kneel on the floor or some kind of position that was comfortable to him. And to that point, I only heard about the benefits that shockwave therapy might have. And I told him, well, you got to be patient number one. So I treated him. And after 6 weeks, was like magic, the pain was gone, and he's still fine today. So then all these patients were dropping by into my office, and I was treating them one by one. And the first 10 to 15 patients, I had 100% success rate. And that was incredible. But then I thought, well, this is maybe not true because this is medicine. You never get 100%. And then one after one, I got some patients who didn't respond. But overall, I think I have a success rate of 80% in the right patients. And the reason why I'm asking this about the erection is when I treated these patients, suddenly one of my patients, we'd never talked about this before, but he said, well, is this normal, doctor? Now at night, I can just drill through my mattress with my erection.
Wow.
So that really got me thinking, is there a connection between pelvic pain or pelvic dysfunction and erections? And I started to ask my patients, and well, a lot of them responded to shockwave therapy this way. So my theory would be that muscles of the pelvic floor connected to sexual function, if they are overactive, they like it shortened very much, so they can't, in men at least, they can't sustain erections. Is that the same experience that you have?
Absolutely. So what we see is that the superficial muscles of the pelvic floor, they are going to contract to maintain the erection, to maintain the filling of the penis. So they're already meant to be in a shortened position during erection. So if you have too much tension already, well, then it's just an overcontraction. It becomes a spasmic type contraction. So we have two things that could be related to the pain, or they're already too tight. And we see this in incontinence as well. So often we'll speak about incontinence in terms of like lax pelvic floor, but that's not necessarily the case. It's control. So if the muscles are already in this shortened position, when they're expected to contract, when we need them, they're too stiff in a sense to do that. So we can see that erections are not maintained. Some men aren't able to have an erection. And then, of course, that spastic pain response that we see. So in practice, what we will do, once we've evaluated and we identify that the pelvic floor is overactive, the first piece of the puzzle is developing that proprioception, because most people are disconnected from these muscles. A lot of people don't even know that they have a pelvic floor, right? And so now we're asking these poor patients to find these muscles that you never see, you never think about, and that are meant to work automatically, put them under your control, and then normalize their function. So it's actually a big task that we're asking patients to do, but it's absolutely possible. And so we'll start with just sensory exercises, beginning to feel a little bit of movement, some manual stretching of the pelvic floor externally or internally. So if it was a man, it'd be anal rectally. For our female clients, cis female clients, we would do it vaginally and anal rectally, depending on what they need. And so once those patients can feel and identify the difference between tension and release, and that's really the first piece of the puzzle, that proprioceptive, that body awareness piece, start to see things change right away. So usually the first thing, some men are even coming in, they're not even getting their morning erection. So they'll start to notice that their morning erections are harder, more long-lasting. There's less pain with them. And as you said, as they continue to practice, we see the erections improve. Once they're able to fully release just in practice with the exercises and the strategies that we're giving, well, then they have to be able to maintain that same release during masturbation. We usually start with masturbation or self-stimulation because there's less going on. It's more of a controlled situation. And so we'll literally have them practice that awareness, the softening of the anus, the relaxation of the perineum during that stimulation to improve that control, essentially. And that usually goes quite well. It's a challenge at the beginning, but every observation that you've described is on point with what we see in clinic as well.
I think most of my patients, they're male, and I would say maybe most of your patients are female, right?
Yes, this 70% of our patients are probably female. Probably see 20% male, and now we have trans and non-binary population here as well.
I think this is the problem because men, in my experience, they don't want to have a pelvic floor, or they are not aware that they have one. Like this is for women after childbirth, and they are not aware of that, and they think this is kind of female stuff, and they don't really want to talk about it and want to have to do something with it. So I think this is a big problem in my work because I have to explain to these men that they indeed have a pelvic floor. It doesn't make it better. I have a pelvic floor. I think you have that kind of thing. It's a female one because the male one was 3 times the price. So yes, I thought the same kind of muscles. So I just used this one. And it's kind of difficult to explain to these men that they also have the same muscles. But this is a big obstacle to overcome in the first place, to tell them that they have these muscles. And the second one, which I think is very important, is that people, or my patients, men in general, think that their pelvic floor is weak, while in my experience, it's the opposite. So I almost never have patients with a weak pelvic floor. It might be some patients above age 80, male patients, I mean. When I palpate the pelvic floor, I really can see that they can contract, the sphincter tones very weak, and the pelvic muscles are very weak. But in general, in my opinion, men tend to have an overactive pelvic floor, normal to overactive. Is it the same experience that you have?
Yes. So on both comments, one, there is a huge taboo where pelvic floor and pelvic health related issues is concerned. I think the paradigm is starting to shift. In general, there's a taboo about it, right? Or a misunderstanding that some of these symptoms are just kind of the plight in life. We just have to live with them because, again, I deal with more of a female population, but still, pregnancy and postpartum, they have urine leakage or they have pain with sex or whatnot. And that's just their plight. Some men, they've never heard of it before. They don't know where to go. They get stuck, I find, in the medical system. And where prostatitis comes in, we can talk about nomenclature a little bit later because that's also something. I think it has a tendency to have men stuck in the medical system a little bit. And so what I see is the pelvic floor piece comes in much later right? So already it's a taboo and it comes in much later, but the emphasis is often on the prostate itself.
Mm-hmm.
But the prostate can become sensitive, but it's the victim to the tension that's around it.
Mm-hmm.
And so what I see in practice is a lot of men, unfortunately, have done multiple rounds of antibiotics repetitively with negative cultures before they finally come and see us in pelvic health, in physiotherapy. So the musculoskeletal portion of that is really the absolute last piece of the puzzle that's investigated. And when they come, most of the time it's because they've done their own research and they've fallen on physio. They've found it online. And so then they've done their own research and access to us. I'm very fortunate. I work with some excellent urologists in Montreal that send their patients right away, and they have an understanding on the musculoskeletal side. So as they're doing the investigations for doing the cultures and the urinalyses and the bladder scans, simultaneously, they're ruling out the pelvic floor musculature. And so that symbiosis works really well to make sure that men are coming in much sooner before the chronicity really sets in and we start developing pain behaviors and avoidance behaviors, and their quality of life is starting to really dip. It becomes a much larger issue. There's sort of like a helplessness that develops in that process, if that makes sense. And to your second point about the weakness of the pelvic floor, it depends on what we're describing as weakness. You're 100% correct. Where men and women are concerned, men will always have the stronger, thicker muscle group. And in pelvic pain, typically it is overactive. However, you can have a short, tight, weak pelvic floor because to generate force, the muscle needs to contract over a certain range. Like it has a certain optimal length to contract to develop force. So if the muscles are already shortened, technically that movement is much smaller and the force can be much smaller. Where the tone is concerned, 100% what you're saying is right. That resting tension is a lot more present in the older population, not necessarily with pelvic pain, but we do see tension and weakness combined in pelvic pain in the younger population, if that makes sense.
Yes, absolutely. And one of the things that you said about antibiotics, then we have another issue because many men of this age group, they have enlarged prostates, which is kind of normal in this age group. And then an antique thinking comes in that all kinds of symptoms are connected to an enlarged prostate. And if you go on YouTube, there are tons of videos telling people this. And I learned this when I was in medical school, but now we know that there are many other reasons for lower urinary tract symptoms, including pain. And it's not an enlarged prostate. So it's a misconception of what enlarged prostates can and cannot do. And in my opinion, there is a certain configuration of the prostate. When the middle lobe is very much enlarged and it's bulging into the bladder, then it can cause all kinds of weak stream and urinary symptoms. But this is more or less it. And I have patients who have prostates like this large and they void perfectly and they can empty their bladder. And I have some patients which have moderately enlarged prostates, which have major problems. So it doesn't make sense in a way to just attribute this to prostate size.
Sure. Yes, absolutely. I think with the enlarged prostate, I do have those gentlemen as well that are just having the lower urinary tract symptoms, like the slow stream, incomplete voiding. And we do see improvement in that population as well. I think where the pelvic pain comes in that we were discussing and the prostatitis, it's that nomenclature, I think, like now in the circles that I'm in, the International Pelvic Pain Society, et cetera, there's a shift towards male pelvic pain or male chronic pelvic pain syndrome, right? So that gives more of a global understanding of why that pain might be there as opposed to just prostatitis. We understand that it's not bacterial, but again, that poor prostate is getting all the blame for these symptoms. And I think patients that I see that come in with prostate in their mind, sometimes it becomes a harder sell, a harder buy-in to the conservative treatment process and the exercises and understanding the pelvic floor, et cetera, because they've already come in thinking, well, there's something wrong with my prostate. Mm-hmm. And so there's a whole dismantling of understanding and a re-education that has to happen at the first session and then repeated throughout so that really patients are, they're sticking to their treatment plan, they're understanding the why behind the treatments that we're offering them. And they really have to understand and shift out of the prostate into the musculature. And again, that's sometimes a big leap for people that are disconnected from that area and disconnected from those muscles, or, don't know that they exist or attributed them to women. And I do have that because when we evaluate men here in pelvic health and physiotherapy, we're often doing it on their back in the lithotomy position, And so a lot of the comments that I'll receive is like, oh, this is very much like gynecology. I'm like, no, this gives me access to everything that I need. But there's a bit of a, there's a bit of a disconnect. They don't understand why they've been sent to the women's clinic. And it's like, well, no, it's for everybody, everybody.
I would be very curious to hear, when you examine patients, what do you do? What's your approach?
So when patients come in for their first evaluation, we do a very thorough history because we want to know about anything that could be impacting their symptoms. So that could be, past medical history, surgical history, obviously, so just in their general history. But then we want to know about urinary function, how often are they voiding, when are they voiding, do they have urgency or urine leakage, do they have triggers for that, is there pain, do they have techniques? So some people push, some people wiggle, some people tilt, plethora of variations. Then we want to know about their bowel symptoms. How often are they going? Again, do they have a technique to pass stool? Is there pain related to that? Can they hold back gas? Can they suppress urge? And then we go into their sexual history as well. Is there pain at the genitals? What is sex like for them? Erection and ejaculation, and then just generalized pain. So anywhere between basically the ribs and the knees is our field of work. And so then once we collected that information already, it signals as to where we should be sort of directing the physical exam. But basically, we'll be looking, again, ribs to knees. Breathing pattern can have an impact on pelvic floor health. We're going to be looking at the abdominals. Often we'll see overactive. So where the breathing is concerned, let's start there. And if there's a persistent pelvic pain issue, it's become chronic and a real dysfunction, we'll see a lot of apical breathing, like a stress breath, fight or flight sort of response. The diaphragm might be tight, the respiratory diaphragm. And then we move into the abdominals. We're looking for tender points, so what we call trigger points in the abdominal musculature. We're looking for just generalized tone or connective tissue restriction. So we're looking at how mobile can we roll the skin of the abdomen into the pelvis? Does it move? Is it restricted? And then we're going to do a pelvic exam. So we're looking at the external genitalia and the groin, just on observation. What does it look like? Are there color changes, texture changes? Again, mobility of the connective tissue. We'll do that on the perineum and the groin, along the scrotum. Does it move? And then we're going to observe their pelvic floor exam. So I'm always curious to see what patients feel a quote Kegel is, just to get a sense of how they've maybe been using their muscles. So I'll ask them to contract. So what we should be seeing is that the anus pulls in, that the testicles rise, and that, you get a little lift of the penis. That's really what you should be seeing without too much abdominal effort. It should be isolated, and then that should be relaxed. The anus should fall back out, the perineum back out, testicles drop, penis relaxes. So that's what we're looking for on observation. So I want to see if there are major compensations. And then we'll do an internal exam. And so again, that's anal rectal for men. And so we're looking at tone of the muscles, so resting tension. I'm looking to see what kind of control of contraction do they have. Can they contract, and what kind of pressure are they able to exert? And more importantly, in pelvic pain, can they let that go? And how fluid is that release? How complete is that release, and how fluid? So some patients, they let go in increments because they're having trouble. Sometimes they let go and it's very slow. It's delayed and very slow. And that's usually elevated tone. And what we're looking for really is a nice, easy, full release where they can get stretch of the muscles in that resting position. And then internally, we're looking for trigger points again. So we will map and touch every muscle of the pelvic floor bilaterally, each side, looking for tender points, areas where the connective tissue doesn't move. We'll do resisted movement to make sure the muscles are responding well and that on contraction pain isn't elicited. Check the tailbone as well, because pelvic floor attaches to the tailbone. And we'll have a sense of sort of what kind of tension and where is that pain being generated from. Externally, we can't forget about the superficial pelvic floor either. So we're going to palpate under the penis and along the bony pelvis to make sure that there's no tension points there as well and in the superficial pelvic floor. So it's an extensive exam. It's thorough, certainly. So by the end of that, we should have a sense of where to start. And that's really the pelvic exam. If we see that that's not adequate, then there might be contributors outside of the pelvis. We don't have tunnel vision. We still are looking at things that physiotherapists look at: posture, general flexibility of the lower extremities and the back. We're going to be scanning all of that as well. But where the pelvic floor is concerned, that would be kind of your typical exam.
And what I think is very important, you had just mentioned it, that the pelvic floor is connected to the whole body. Like it's the central control system which connects the lower body to the upper body, and has some connections also to the breathing muscles, to the diaphragm. And I try to tell this to my patients. They just can't believe that this might be true. So my question to you would be, breathing exercises is a good thing, but they can be kind of boring. What about singing, playing wind instruments? Would that be helpful?
Oh, that's a really interesting question. More and more, we're seeing the connection. I actually just saw a course being offered yesterday about the voice and the pelvic floor. If you look at the glottis of the throat, it actually looks very much like a vulva. There is definitely a connection there. So first of all, yes, there is very much a connection between the diaphragm and the pelvic floor. So basically what we see is that the respiratory diaphragm is the trampoline under the lungs, and your pelvic floor, you can think of it as a trampoline under your pelvis. And so when we're taking in air, we're filling up the lungs, which causes the respiratory diaphragm to descend, which puts pressure into the abdomen, intra-abdominal pressure, which is then going to push the pelvic floor away. So on inhale, everything drops and relaxes into the pelvis, and on exhale, things rise. And so we can absolutely use the breath indirectly to affect pelvic floor release. And that's an exercise that I often give. We'll have patients use the bathroom, seated, men included if they're having pain, because the pelvic floor is postural. So we want to make sure that it's completely off. And so we have them sit to void or defecate. And then we'll have them stay seated in that relaxed, open position and inhale, plunger that breath down into the abdomen and into the pelvis, trying to perceive that expansion of the pelvic floor and the anus down towards the toilet. And that becomes one of their exercises to practice right at the beginning of our work, because the program to relax has just happened. It's in that context of the bathroom where it's okay to let go. So the brain gives the pelvic floor permission to do that. And then we're working on that. Now, your question about wind instruments, you know what? I'm not sure. And the reason I would say is singing, perhaps. I have had patients come in with incontinence, opera singers, and a couple of opera singers actually, and a saxophonist that came in with incontinence issues. Both of the opera singers had overactive pelvic floors. The saxophonist had a weak pelvic floor, like weak impacts. So I'm not totally sure about the mechanics of that. My gut would say if you're really forcing to create tension in the diaphragm and the abdominals to project, that could potentially, if you're already having pelvic pain, so if you're already tending towards overactivity, possibly it could contribute. Possibly. So I would actually say that to relax your pelvic floor and to gain more mobility in that pressure system would improve your stamina using your wind instrument and actually maybe free up that projection if you were singing, if that makes sense to you.
Yes, it does.
I'm really curious. That's good. I'm going to look into that, actually. I'm curious. Maybe I'll take that course on the glottis.
Maybe. And talking tension, that would bring us to the next topic, Kegel exercises. Men love Kegel exercises, and they're all over the internet. My personal opinion on Kegel exercises is they're good in certain patients. So if you have examined a patient and think this might be a good thing to do, then it is. But given the fact that many men have overactive pelvic floors, I think this would be a catastrophe to put Kegel exercises on an already overactive pelvic floor. What do you think?
100%. Absolutely. Again, I always, when I'm explaining to patients, I try to make things as practical as possible. And so I say, okay, well, if your bicep is already contracted, and then we're contracting it 30 plus times a day more than it's supposed to, it's understandable that you're going to have pain there. So for me, that Kegels are not one size fits all. I often speak about what I've termed the Kegel conspiracy, which is exactly that Kegels are for everyone. We have to remember Kegels need to be prescribed. First of all, for the audience, what is a Kegel? A Kegel is a contraction of your pelvic floor, a maximum contraction of your pelvic floor. And really, the history behind that was in 1950, a gynecologist noted that women that had urine leakage, if they were doing, at the time, I think he was prescribing 200 a day, contractions of the pelvic floor, they had less leakage. So we were thinking of Kegels in terms of strength. But again, if your muscles are already tight, strengthening is not what you need. You need to learn to let go. And we need to speak less about pelvic floor strength and probably more about pelvic floor control, that full range of motion. Can you fully contract? And can you fully let go? So doing a lot of Kegels with pelvic pain, that's not the appropriate approach. And it's true, there is a lot of information out there. Now, the male patients that I work with that do need the Kegels, and it's been shown in research that it helps, would be my prostate surgery patients. So there is research that shows, recent research, 2019, shows that high volume pelvic floor contractions pre-op and post-op quicken continence in that first 3 months post-operatively. And so we do put men on a very high volume Kegel program. However, if they're referred and we evaluate that the pelvic floor is tight, we have to relax the pelvic. They have to gain that full control first before we start them on the high volume, so that we're not creating a problem either. So there is an appropriate population for that, but it's not one size fits all at all. So I'm glad that you come to that conclusion, because it's completely on point.
I totally agree, because in an earlier life, I was the chief of a rehabilitation hospital for urologic rehabilitation, and we did lots of these strengthening exercises after radical prostatectomy. And I refer all patients, when I see a prostatectomy coming around the corner, I send them to physiotherapy to learn how to feel their pelvic floor muscles, because it's much easier. Also, this is also a point, it's easier before the operation to get accustomed to this area and to feel what it feels like than after the operation, when everything is altered, and it's much more difficult to feel that. And I also believe that when you start with this early, before an operation, this will contribute to better outcomes after radical prostatectomy.
Yes, absolutely. The fact that generally post-prostatectomy men will have a catheter in place for a number of days, all of that changes the perception the brain has of that region. So we're just getting back normal sensation and basic control after a surgery like that. So absolutely, to create a muscle memory pre-op is very, very valuable, and should also develop the habit of doing the exercise. Let's be honest, it's extra. It's extra. And the protocol that we have our men on, it's 6 times a day. They're doing about 20 contractions 6 times a day. So it's high volume. So to even just learn how to carve out that time and to get into the habit, because at the end of the day, regardless if we're treating pelvic pain or incontinence or erectile issues, the consistency with the approach will produce better outcome. And that's habit forming. And so there's that piece of the puzzle as well that becomes really important. So the earlier they're sent pre-op, the better, I find.
It was a fantastic session we had. Thank you very much, Amadea, for coming to my channel and to contributing to pelvic health on my channel. Everybody who's listening to this, check her out. You're on Instagram, right? That's your main channels. So it's Ask Physio on Instagram. Follow her. This is fantastic information that you can get there on Instagram on her account. See you next time. Bye-bye.
Thank you. Take care.